Dr. Chugh, you published extensively. Would you specifically mention and highlight some of your key research interests?
Yes, I have published about 400 papers. Sometimes I wonder myself, how could one achieve during one's life? But I must also admit, it is not my personal contribution. It has been largely the efforts of my fellows who had been working all along, and also my colleagues in the department and from various other departments in the institution, that we could produce a lot of work which was accepted and which received not only national attention but international attention. The first striking thing was when I did my biopsies, renal biopsies for my thesis, 12 out of 60 patients had renal amyloidosis. It was a very surprising. And therefore, we started looking at the pattern of glomerular disease as was seen in our part of the country. When we started doing dialysis, we found that there was a very heavy load of patients with acute renal failure. And these patients were totally different from what the rest of the Western world was seeing. For example, the commonest cause of acute renal failure was severe diarrheas and dehydrations and volume depletion, and also renal failure in obstetrical practice, both following septic abortions as well as following later in the pregnancy. One of the very striking features was that when we analyzed our patients of acute renal failure, and I used to do biopsies on all of them, that 25% of the patients had acute cortical necrosis, which was the highest incidence quoted by anywhere in the world. And when we published this work in the Green Journal, Obstetrics and Gynecology, I was invited for presenting this work both in the United States and UK by various centers. And therefore, working on the pattern of tropical acute renal failure was the beginning of a very big project in tropical nephrology. Also, that we started meeting with patients with renal failure due to, say, snake bites or bee and wasp stings, which are not seen anywhere in the world. And therefore, whenever we sort of compiled our data on such like tropical problems, the international journals accepted it immediately, and then we were quoted by everybody on this work. After this, for example, leprosy and tuberculosis are problems in this country. So I worked on renal disease in these tropical diseases. Also, we found young people who were not suffering from renovascular hypertension of the classical type, for example, due to fibromuscular dysplasia or renal artery stenosis, as they see in the West. We started finding that these patients were really suffering from Takayasu arthritis. And therefore, our interest began in the investigation of patients of renovascular hypertension. And we found that 60% of the young patients suffering from secondary hypertension were due to Takayasu's disease. And that we published extensively again. I also worked on various aspects of, say, dialysis and transplantation, particularly the tropical infections which are common amongst these patients. The fungal infections which are so commonly seen and are not seen in the rest of the world, or a high incidence of tuberculosis amongst our transplant recipients who were on immunosuppressive therapy. We also worked on the economical and ethical aspects of renal disease, and in fact have contributed chapters on ethical issues in a renal transplant and other renal diseases. So I think we largely concentrated on tropical problems or problems of the developing countries. And that is what I feel. We didn't go into highly sophisticated research involving genetic level, which was of course not there at that time when I was working, but even otherwise, not on very sophisticated kind of work, but on the problems which were facing us in our own country. And I think that is how we could publish a lot. Not only publish a lot, I was invited by several international textbooks to write chapters. For example, I've written in Oxford textbook of nephrology, I've written in Oxford textbook of medicine, I've written in American books, say the kidney disease by Shaul Masri and several other Oxford series. Not only that, our work attracted the attention of WHO, and I've already said that I became a part of the WHO team, the editorial team, which published the book on classification of tropical renal disease. And the same way, the nephrology forum I published was on the same topic like venom-induced, snake venom-induced renal disease, on which we had worked both clinically as well as in the experimental animals. We used monkeys for that. And therefore, my research has largely involved tropical problems, and that did attract a lot of international attention.
Dr. Chugh, what has been the most touching moment in your professional life?
I can cite several of them. Then when you say most, I could cite at least one which really struck me. And that is, it happened when one of the physicians by the name of Dr. Rajinder Chugh, who was the personal physician of one of our late Prime Ministers, Lal Bahadur Shastri. In fact, he accompanied him to Russia also, and was a well-known figure, nationally and internationally. He met with an accident in the country in which he died, his wife died, and only one daughter had survived. And the news was flashed all over the world that Dr. Chugh had died in an accident. When this news reached some of the friends who knew me well, perhaps didn't realize which Chugh it was, they learned that Dr. Chugh has died. They all thought that I had died. And therefore, my wife started receiving lots of phone calls expressing their condolences, and we received lots of letters. In fact, the letters were so interesting. Several of them wrote about how good I was, what a kind of bright, professional, academic person we have lost from the world, and several tributes, which I still possess the copies of those letters with me. Several of my friends expressed that I was such a good host, and all qualities which one can think of, or even, in your lifetime, they were all written. And I thought that I was reading my obituary in my lifetime. I was very touched. This was largely from my friends who had been sincere friends. But then when you learn about such things, that how the people think about you, you do become emotional. The second incident where I read my own obituary was another time, and that was in 1998. Martinez Maldonado wrote an editorial on me in the American Journal of Kidney Diseases, and that is the series which he had started editing in every issue of the American Journal, he picked up. I don't know who picked up, but I think I was sixth or seventh to be picked up in the whole world from nephrologists, on whom Martinez wrote an editorial. And when this editorial was published, the next was a page on which he had written an obituary on Dr. Frank MacDonald. When the current contents listed all these, as you know they do, under the obituary they mentioned my name instead of Dr. Frank's MacDonald's name. And it so happened many people read, and again we started receiving, letters. But the most touching was from my former mentor, Dr. Oliver Wrong. Dr. Oliver Wrong, while sitting in St. Mary's Hospital in London, read the current contents and found that Kirpal, who had been working with him, had died. He thought of writing a letter of condolence to Harjeet, my wife. But as a research worker he is, he thought I must first confirm from the American Journal of Kidney Diseases as to how it had happened and what was, the facts behind his death. So he went to the library and took out the journal and found that the obituary was on Dr. Frank MacDonald rather than on me. So he wrote a letter, which you can see for yourself. And thus I was reading my obituary second time, and Oliver Wrong mentioning that you can join Mark Twain in saying that your death has been exaggerated.
Dr. Chugh, I also saw tears in your eyes in 1994 when your students had arranged a festschrift for you at the 25th Annual Congress of Indian Society of Nephrology at Chandigarh. Do you remember that?
I remembered that moment very vividly. I think this was another touching moment for me. When your fellows, your colleagues, sort of present you with their feelings, and I think that was an emotional moment when they celebrated my festschrift and presented in their own hand, signed a plaque and also a memento. I was very touched. The fact remains that I was taken or considered as a very strict disciplinarian during work. I firstly did not encourage anybody coming late to the meetings or to the wards or to work. And I did set an example myself. I would never be late in the meeting until unless a crisis had occurred. And therefore, I set an example that we must be on time for all activities. For example, even taking my bedside rounds and so on, I never shirked from it. Even if I had come from outside, even in an international meeting, and reached 2 hours earlier, and if a bedside round was there, I never missed it. One can say that one can lead, but a leader doesn't have to lead only, he has to set an example. So therefore, at that moment, perhaps my fellows must have felt very angry with me that I was such a hard taskmaster. If I gave a job to somebody and he didn't bring it at the right time, I was not very happy. But I did the same. If they gave something to me, for example, a paper to read, the paper was back to him next day. And therefore, as a disciplinarian, I was considered as very harsh. But at the same time, I think the love and affection which I received from them, and also what I like to do from them, they knew it very well. I never spared an opportunity if I could be of any help to any of my fellows or colleagues. I always went out of the way to do that for them. I think that they all realized, and therefore this affectionate fellowship was a very special moment for me.
Dr. Chugh, what has been the contribution of your family to your growth?
I must say that it's quite true that your fellows, your colleagues are important because they are the ones who make your academic career. But I think the happiness which I had all my life was largely contributed by the support which my family gave me. I think my wife, well, in that process suffered a lot because I used to go early. I would leave even the breakfast table if I'm getting late. I would come back late in the evenings because I was busy at work or writing papers or doing some projects. But she bore all that. Not only that, I was away for meetings, for conferences, for lectures in the country, outside the country, so many times, and that she had to stay back. Well, in those days, we financially couldn't support the travel, of the family, and most of the time I was alone. I must say that she gave me a tremendous support, and she was very understanding. And lastly, all the social obligations which I couldn't meet with were largely done by her, always with a smile. My children, Sumit and Sumant, who are now, of course, they are academics. One of them is a nephrologist at the moment in Northwestern University of Chicago, and Sumit, who is a cardiologist earlier in Mayo Clinic and now in Portland. They again, I think, whenever I was in tense moments, they always helped me and cheered me up. They were also very understanding, and I must say the love and affection and the happiness which we had in our family was a big support for me.
What do you consider the current status of nephrology in India, and how do you foresee the future of nephrology in the country?
I think over the years we have come a long way. I can certainly say that Indian nephrology is now amongst the nephrology or nearing the nephrology in the frontline nations of the world. Because of the fact that during the last two decades, lots of new centers have come in private sector as well, because the government institutions have limitations, financial limitations in the service programs and in the investigations. We now have hospitals in the country which can provide service, which is available, the best possible service anywhere in the world. And therefore, I say that the standard of nephrology over the years has gone up tremendously. Although not very pleasantly, I would say that the people have been coming even from Canada, Europe, or from Middle East countries over to our country for receiving, say, kidney transplants, although it was for different reasons. But sure enough, they realized that the standard of therapeutic care which was available in India was equivalent to any other country, and therefore they came to India. Although, as I said, this was not the entire reason. The entire reason was the availability of organs in our country from living donor sources. So therefore, as far as the therapeutic facilities are concerned, they have advanced, and we are at quite a reasonable level of good care which we can give to our patients. On the investigative side, also, now we have facilities available in bigger hospitals for any kind of investigations which are available outside. The work has started even at the genetic level or say immunological level. For example, the various experiments on tolerance being done in the country meet with the standards of investigation which are available in the advanced centers. Currently, we have about 400 dialysis centers as far as the management of renal failure is concerned, with about 13,000 or 14,000 stations. On an average, we have about 8 to 10,000 patients who are on dialysis. Now, this is a small fraction of the patients who require care for end-stage renal disease. For example, in our country, we have about every year 100,000 or more than that new patients. Yet only about 10% of the patients can avail of this facility of renal replacement therapy. This is largely because of the financial problems. Firstly, there is no governmental support available. There have been no insurance companies supporting the chronic, say, dialysis facilities. Therefore, most of our patients have to meet with the expenses on the treatment from their own resources or from charities. Some of the industrial houses do support their workers and provide the financial assistance. But till the time it can happen from the government side, which at the moment they have also a genuine difficulty, majority of the patients in our country cannot receive the kind of care which they require. So it's a small percentage. At the moment, we are able to do about 3,500 transplants every year in the country, but they are again largely from the living donor sources. Despite the fact that the Act has come up since 1994, where the brain death has been recognized, and we could have done far bigger number of cadaver transplants, we have done very little so far. Not more than 600 cadaver transplants have been done after 1995 when the Act came up. Therefore, as far as the feasibility is concerned, we have no problem. The technical expertise and the facilities are available, but our problems are financial at the moment. If you compare, say, the per capita income of India, around $500, with say 35,000 or 40,000 in the United States, you can understand the difference. You know why we have problems in providing the kind of care which one would like to do it to all our patients. We are unable to do so. From the research point of view, I think we need to do a little more than what we have done so far. We have still not tried to establish a registry in our country to know the pattern of disease, and therefore exactly what is happening in the country can be known only once we establish a registry. I think we need to do a little more. As far as the training facilities are concerned, we have now about 15 or 16 centers in the country which are running postgraduate courses like DM nephrology, and I can say majority of these centers have adequate training facilities, and all the fellows which are trained in our centers have good basic training, and I can say the test is whenever they go out, they fit in very well if they have received training from our centers. The National Board of Examination has also recognized many centers, and several centers are running the National Board courses. Earlier on, lots of people used to go to United States or for UK for training, but I can say that trend has decreased significantly, and many of the postgraduates, when they come out after their training, they sort of feel that they are well trained, and now they sort of can continue their professional careers in the country.
Dr. Chugh, with your achievements and the stature that you have achieved, I'm sure you are a role model for many young nephrologists. Have there been any role models for you as well?
Of course, yes. I think three people who have been leaders in their own fields have influenced me tremendously. The first one was my mentor during my earlier career, Dr. P.N. Chutani, who was himself a gastroenterologist. But I think I learned the quality of discipline and also the message of a clear expression which he used to have. I learned that from Dr. Chutani. The second person who influenced me in my research was Dr. Oliver Wrong in the Hammersmith Hospital. He was such a thorough investigator, wouldn't ignore even minor irregularities which might crop up. And right from the beginning of my career, I learned that there is no replacement for an absolute clear and a thorough investigation whenever you are pursuing a project. But the person who influenced me most in my nephrology career, I regard Dr. Stuart Cameron as the one whom I still feel, right from the beginning, when I met him in 1968, I was so much impressed by the way of his teaching, the way of his writing papers, the way of dealing with your fellows. I think these are important things which shape your career and your dealings with your colleagues and fellows. I think I learned a lot from Dr. Stuart Cameron. There have been several others whom I have been in touch and have influenced me a lot, but I consider these three persons as my role models.
Dr. Chugh, who are the other Indian nephrologists who have been recognized in the country or internationally?
Yes, there are several Indian nephrologists who have received national and international recognitions. A few names come to my mind at this time. They are Dr. Ramesh Khanna, Dr. Sutentran, Dr. Yashpal Kanwar, Dr. Kasinath, Dr. P.C. Singhal, Dr. Vinod Bansal, Dr. Anupam Agarwal, and many others actually who have contributed a lot to nephrology in the world. Some of the Indian nephrologists who have been honored by the highest civilian awards by the Government of India include Dr. M.K. Mani, Dr. R.V.S. Yadav, and Dr. Ramesh Kumar. Some of the senior nephrologists from India who are recognized all over include the contributions made by Dr. K.K. Malhotra and Dr. V.K. Acharya. I think these are the names, but there are many others who have received the international and national recognitions. also the International Society of Nephrology and the Kidney International has recognized the contributions in the field of nephrology by awarding nephrology forums. And I cannot help but saying you are amongst one of the two nephrology forums which have been conducted in India by the Kidney International and which has been sort of taken as an authentic account of the end-stage renal failure problem in the country.
Dr. Chugh, you spent some time in Nigeria. What was your experience like in Nigeria?
Yes, I was in Nigeria for about 3 years between 1982 and 1985. Actually, the new university of Maiduguri in north of Nigeria had started a medical school recently at that time, and they wanted to establish a dialysis center. Requisition came through the government of India, and I opted to go there, and I thought I will go and help them in setting up a center. When I read there, we made an assessment, and orders were sent by the medical institution for purchase of 4 dialysis machines. However, in the next 3 or 4 months, the equipment had still not arrived, and at that time there was a military coup in Nigeria. And following the coup, they cancelled all the orders for the equipment which had gone to United Kingdom, but unfortunately we never got the equipment, and therefore I couldn't help them in setting up the dialysis center. However, I found that there was an immense material on some of the tropical problems which I had never seen in India. For example, schistosomiasis was very common. Similarly, sickle cell disease was so common, and also the renal disease due to malaria and snake bite were very common. So therefore, I thought I'll involve myself in working on these problems because they had still not been worked out from those countries. With that aim in mind, I started the projects, and I wanted the help from my local Nigerian fellows and colleagues. And I would, like the way I was used to the PGI culture of time, reaching the hospital and the institution at 8 o'clock in the morning, but my colleagues wouldn't accept this timing. They in fact complained to the Vice Chancellor that this Indian doctor calls us early in the morning, which is too early and we cannot make it. In any case, when I started a project on urinary schistosomiasis in medical students, and we collected the material in 2 months' time, I sent a small paper to Lancet, which was accepted immediately. And in this paper, I had put the names of all the fellows who had worked on this project. Once this paper came in the Lancet, they all came to me and said, "Sir, we are ready to come at 8 o'clock or any time you call us." And the fact is, henceafter, we started working on various projects, and in 3 years' time, we published about 19 papers in national and international journals from that center, which nobody had done at that time. Another striking feature was their culture of work was not there. I wanted to start clinical meetings and journal clubs, and in the beginning, when I started these, there were only 5 or 6 people who would attend these meetings. I tried to sort of coax all the departments, ask the professors that they present interesting cases, and I started doing it myself. Our dean and professor and head of the department was Sir Scarborough, who I hope many would know that he was the editor of the book on Bell Davidson and Scarborough's physiology book, and he was a clinician who was in Boston for quite some time, originally coming from Cardiff in UK. And when we started these meetings, the people found these very interesting. Within 2 or 3 weeks, this was a weekly meeting, we found that the attendance increased from 8 or 10 people to about 20, and in the following 6 weeks, the attendance became 50 to 60, and in 2 months' time, we found that more than 150 people, more than the hall could accommodate, would like to come and attend these meetings. And therefore, I was successful in creating a new kind of atmosphere in that medical institution. And the result was that when the meeting started at 2 o'clock, 2:05, we had to board the door because there was no room inside. Thus, I became a very popular physician amongst the Nigerian staff, and to my surprise, 6 or 8 months after my arrival in Maiduguri, Sir Harold Scarborough wrote to the Vice Chancellor of the university that in view of the outstanding research projects which have been started and the way the clinical academic atmosphere had totally changed with my arrival there, he recommended that I become the head of the Department of Medicine and he would work under me in that department, and he did so. I must say, it was indeed very great of Sir Harold Scarborough to have done that till he retired, and I in fact remained the head of the department. Finally, Sir Harold Scarborough died in Malta, and his obituary appeared in Lancet, which was written by Dr. Keith Peters, and I found my name in his obituary saying that one of the outstanding persons he had worked with in Nigeria was myself. I had a very pleasant experience of my stay in Nigeria. I could mold my local colleagues in the department to an academic and a research atmosphere in that institution. And finally, they had never done anything like this before. When I retired, the whole university got organized a dinner in my honor when I wanted to come back to India, which had never been done before by the university as a whole for any individual staff member of the medical institution. So I had a very good experience, and I must also say, because of the work which I published from Nigeria, ultimately when there was an international congress of nephrology in London, I was made the chairman of the scientific session on parasitic renal disease and the kidney on the basis of the work which I had done there. So I had a very pleasant experience. My only regret was that during my stay, the kidney machines never arrived.
Dr. Chugh, what will be your advice for the young next generation of nephrologists of India?
I would like to give a message not only to the younger colleagues, but also to those who are not so young. I feel that the cardinal attribute of a medical doctor, which has given him a distinct status in the society and has placed him at a higher pedestal than the other professional, is that the ailing humanity in their suffering regard the doctors as their saviors next to God. It is imperative that the society would also expect the doctor to be different from the other professionals. Whereas we must work hard and with honesty, dedication, and devotion to excel in our profession, but at least we should keep in mind two important requirements of our patients. And that is, the patients need more sympathetic attitude than we normally give. And also, they need a hope, because hope may be the only thing they have at that time. Let's not deny them of that hope. In our endeavor to provide the latest treatment to our patients, we must not fall prey to the unethical practices for minor financial gains, which unfortunately seem to be slowly creeping into our profession. Secondly, in our earlier times, the teacher was regarded as a guru and his student as his disciple. The guru participated not only in the teaching but also in his career and character building. The relationship between the teacher and his student today is becoming more and more mechanical. I have no doubt that the teachers always try their best that their students become excellent scientists, researchers, and clinicians, but they have stopped participating in their character building. Let's not neglect that important aspect of training so that they also become better human beings in the society. Lastly, the developing world faces newer challenges because of the technological advances which are occurring in the Western countries. Let us not ape the advanced countries, and we must realize the limitations of our patients in the underprivileged world. We need a newer generation of scientists who could use innovative approaches to make the treatment more cost effective and affordable so that even the poorest in these countries can make use of such treatments. We also need to lay more stress on preventive aspects. I have no doubt that the younger generation is capable of accomplishing these objectives. That's my hope. I wish them all a success.